These are 10 rules for use of antibiotics, and this is best practice. I will illustrate these with the help of case studies. So the first one is case 1 is 24-year-old male with fever, arthralgia, and rash. This has been going on for 2 weeks. He feels uncomfortable. So we start IV ceftriaxone. Now, is that the right thing to do? Starting antibiotic just because he has a fever? The first rule is don't start antibiotic just because a patient has a fever. Antibiotics are not antipyretics. You need to know what you're treating. Do you know? If you don't know, have you started workup? Have you started your diagnostic workup to find out what's causing the fever? Could this be non-infectious fever? Could this be a viral infection? The second case, 66-year-old in the ICU for 2 weeks. He has pancreatic cancer and CHF. He has respiratory failure. He has a chronic decubitus wound and chronic biliary drain. His cultures from the BAL are growing Candida. Wound cultures are growing Pseudomonas. His biliary drain is growing VRE. Antibiotics are started. Fluconazole, Zosyn for the Pseudomonas, and linezolid is started for the VRE in the biliary drain. Now, so the lesson to learn here is do not treat colonization. You have to ask yourself, is this infection or is this colonization? So first of all, please remember that Candida in the sputum cultures or in the BAL samples usually in the urine cultures does not signify that it is a pathogen. Candida does not cause pneumonia. Candida in the sputum culture and BAL sample does not need to be treated. You will not find any cases of Candida pneumonia in immune-competent patients. So the second was the Pseudomonas in the wound culture. You have to ask yourself whether this is a colonizer or is there a wound infection. Does the wound have signs of wound? Are there any clinical signs of wound infection? If there aren't, then Pseudomonas is a colonizer, and it is a common colonizer in patients who are hospitalized for prolonged periods of time. So if the wound does not have clinical signs of infection, you don't need to treat that Pseudomonas. The VRE in the biliary drain, remember drains usually get colonized within 48, 72 hours. If this is a brand new drain and a culture is obtained while the drain was placed, that's a different story. But usually on chronic drains, if you end up culturing the contents, you will find nosocomial organisms, usually VRE or Pseudomonas. So do not treat colonization. Move on to the third case, 49-year-old admitted with MI. Blood cultures are drawn. 1 out of 2 blood cultures are positive for coag-negative staph, and vancomycin is started. Please remember that coag-negative staph, single blood culture, is usually a contaminant. It's a skin flora, just like Corynebacterium or diphtheroids. Single positive blood culture for coag-negative staph is usually contaminant. Now, if you have multiple positive blood culture for coag-negative staph, that's a different story. Coag-negative staph is usually not a pathogen if you don't have any prosthesis. Patients with ICDs, pacemakers, or prosthetic joints or prosthetic heart valves, coag-negative staph could be a significant organism, but otherwise it's a contaminant. However, please remember that I'm talking about coag-negative staph. Coag-positive staph, on the other hand, is a totally different story. Coag-positive staph, or Staph aureus, is the most common cause of native valve endocarditis. So coag-positive staph should never be considered a contaminant. That was number 3. So also remember, when you are taking blood cultures, you should take 2 blood cultures. If it's worth drawing blood cultures, it's worth drawing 2. Case number 4 is a case of a 45-year-old with alcohol abuse who's been having fevers for 2 days. And his chest X-ray shows a lobar infiltrate. So Zosyn is started for pneumonia. So remember, don't use Zosyn for everything. Zosyn is a wonderful drug. It's a very broad spectrum antibiotics. The rule of antibiotic use is you want to use the most narrow antibiotic whenever possible. It should be reserved for resistant gram-negative organisms, and same goes for meropenem, all the other prospective antibiotics. If you have somebody in the ICU, if you have somebody who's you think there's suspicion for resistant gram-negatives, and then you should use it. Otherwise, you want to use the most narrow antibiotic as safely as you can. Prospective antibiotic therapy will not only cause increased resistance, it will also increase patients' risk of ulcerative colitis. So remember, the third rule is do not use Zosyn for everything. Always try to use the most narrow antibiotic. Another misconception is anaerobic coverage for aspiration pneumonias. Majority of the time, you don't need anaerobic coverage for aspiration pneumonia unless you have somebody with a lung abscess. Case 5 is a 70-year-old male with stroke. He's admitted from home with pneumonia, possibly aspiration. So he started on ceftriaxone and clindamycin, but he has a history of allergy to penicillin. Given this information, antibiotics are changed to IV ertapenem. So remember, if somebody has type 1 penicillin allergy, you don't want to use beta-lactams. So when I say type 1, that's the immediate IG-mediated anaphylactic type reactions. So always ask the patient about the type of, always get more history from the patient regarding the allergy. Was the reaction immediate, or was it just a rash after a few doses? Was there any hives or airway compromise or hemodynamic instability requiring hospitalization or ICU stay? So in those cases, when you do have somebody with type 1 penicillin allergy, you want to use aztreonam and not a cephalosporin or a carbapenem. Case 6 is a 34-year-old female with fever, dysuria, hematuria, flank pain, no nausea, vomiting, or diarrhea. Urine analysis shows pyuria or leukocyturia, and IV Cipro started. So remember, there are certain antibiotics which are 100% bioavailable. So if the patient can take PO and if they're not having nausea, vomiting, whether you give these as intravenous or oral, the bioavailability is the same. In case of quinolones, the only thing is you have to just avoid milk products, dairy products, polyvalent cations like calcium, magnesium, iron pills, because they can interfere with absorption. You just space them out with the timing of the antibiotic. Other antibiotics that are 100% bioavailable include Flagyl, linezolid, clindamycin, Bactrim, voriconazole, fluconazole.